Welcome to another video. This one's going to be about respiratory mechanics, and it's going to be part of the human physiology playlist. So let's get right into it. Okay, so before we start talking about some respiratory mechanics, we gotta set a couple of formulas down, and we gotta take a look at a little bit about the anatomy of the lungs and the thoracic wall, just so we're all on the same page here, okay? So, first things first. Let's look at the anatomy of the lung here, and that's just, very, very briefly. So, this little tube here, okay, is going to be called the trachea, okay? Also known as your windpipe, okay? It's covered in a lot of cartilage, which actually helps it withstand the ever-changing pressure that's going on here, okay? And then, from the trachea, you're going to split off, obviously, into the right and left primary bronchus, or bronchi. So you got the right and left primary bronchi, which obviously will start dividing about, 23 to 25 times until you reach the terminal bronchioles and all that stuff, okay? Now, what else? What else is there? First, this guy here, this is known as the chest wall, okay? So this view that we're looking at here, imagine I'm slicing somebody in half and I'm looking at them from front view, okay? So this is the chest wall here, okay? And it's really all of this is the chest wall, okay? What else do we have here? Well, in black, this is going to be the ribs, okay? Then we have a couple of other structures here. So in black, okay, if I zoom in black is going to be the actual lung tissue itself, which is very elastic, okay? It's made up of a lot of elastin proteins. Now, surrounding the lung is going to be something known as the visceral pleura. The visceral pleura, okay? Now, anytime you hear viscera, I want you to think about organs, okay? So the visceral pleura surrounds an organ. What organ does it surround? It surrounds the lung, okay? Now, there is another pleura in green here. It is the parietal pleura. Parietal pleura. And not shown here, but technically the parietal pleura attaches to the chest wall and attaches to the diaphragm. Which brings me to this side here. What is this little dome-shaped muscle? This is the diaphragm. Okay? That's the diaphragm. So the parietal pleura attaches not only to the chest wall, but also to the diaphragm, which is very important, okay? So why am I mentioning all this? Well, there is a space that exists between the parietal pleura and the visceral pleura. That space between them, what that's called? That space is actually called the pleura, or the pleural cavity, or the pleural space, or the pleural sac, whatever, okay? And inside of this space, there's a serous-like fluid that's being secreted by the surfaces of the pleura, okay? So the surface of the pleura actually secretes some sort of fluid, okay, which is protective. Now you might be thinking, okay, well, why is there a fluid being secreted here, and what is it trying to protect? Great question. In reality, this image that I've drawn here is very exaggerated, and that's okay because it's for the purposes of learning. But in reality, in your body, the parietal pleura and the visceral pleura are very close to one another. In fact, they're almost attached and they're always touching, okay? So when we inspire, the lung gets bigger and the visceral pleura gets closer to the parietal pleura, right? It expands into the space, the lung, and we'll see that. But then when we expire, it gets further away. This constant rubbing against one another and touching that is going on between the visceral and the parietal pleura creates a frictional force here, okay? And to protect from that frictional force, That's why we secrete that pleural fluid, okay? It's the intrapleural fluid, okay? Intra meaning inside, inside of the pleura, okay? So right here. All right. And in fact, in certain cases, for example, like pleurisy, when this is actually not there, this might actually lead to the inflammation of this cavity, which is not what you want, okay? So the fluid is very important. All right, that's that. Now, a couple of other things I have to mention is the lung, as we said before, the lung tissue is very elastic, okay? It is very elastic. What does it mean to be elastic? Think of a rubber band, okay? I stretch the rubber band and then boom, as soon as I let go, it recoils back to the smallest size possible. That's the exact same with the lung, okay? The lungs are very lazy tissue. They do not like to be inflated, okay? They always want to collapse, or I should say recoil, to the smallest size possible. That's what they want to do. Okay, hence this arrow here. The lung wants to go this way. It wants to get smaller and assume the smallest size possible. But there is an opposing force here. The chest wall, due to its natural elasticity, wants to actually move outwards. And you can actually see this in people with a collapsed lung. You can see that their chest wall is actually poking outside, okay? And you might be thinking, well, hey, Kian, why is it that the chest wall wants to go outwards and not inwards? And it's just due to its natural elasticity. There are many elastic things within the chest wall, right? The connective tissues, the cartilage, the bones, they just have an elastic nature to them, so they like to go outwards, okay? It has nothing to do with the muscles. They just go outwards. That's what they like to do. So you can see how this is causing, an issue here, okay? But really, this is important, okay? This is important because the lung is attached to the visceral pleura. The chest wall is attached to the parietal pleura. If one guy pulls this way, right? If one guy is pulling that way, and another guy is pulling that way, okay, we are going to separate these two pleura from one another, because remember I said normally they're very much attached, but we're going to start separating them from one another and creating this space here. So that's how we come about and create this very small space that we call the pleural cavity, okay? And in fact, because the chest wall is an airtight sealed cavity here, this means that this area is going to be negative in pressure, okay? So negative pressure. All right, that's that. Okay. Key takeaways here is the anatomy and that the lung, in and of its own accord, always wants to recoil back to the smallest size possible because it's elastic, and the chest wall wants to go outward. The interplay between these guys pulls the viscera apart slightly, ever so slightly, to create that pleural space, and because of that, the space is negative, okay? And I'll tell you why the space is actually negative. Because if you notice here, I'm increasing the volume here. I'm increasing the volume in this parietal space, right? Because before there was no volume, right? There was very little volume because the visceral and the parietal pleura were touching. But as I pull them apart, because of the elasticity of the chest and the lung, what happens? The space, the volume in this cavity goes up. And if the volume goes up, the pressure goes down. You might be thinking, hey, where are you getting this relationship? Where did you just come up with that? No. A guy named Boyle came up with that, okay? So Boyle's law states that P1 V1 equals to P2 V2. Now, if you're not good at math, don't worry, okay? This is a relatively easy question to do, but really what I want you to understand from this is the relationship that we can draw. We can say that pressure, based off of this formula, is that pressure is inversely proportional to the volume. What does this mean? This means that as my pressure increases, the volume in that area decreases. You can also say it the other way around. If the volume in a space increases, the pressure in that space decreases. Okay, so we can relate this. We can relate this to this pleural space. we said that the volume in this space was increasing because of the the lungs pulling on the visceral pleura and the chest wall pulling on the parietal pleura to create this pleural space. And they're expanding the volume in here. If they're expanding the volume in here, that means the pressure is going down. That's why we have a negative pressure in this space. Awesome. Awesome. So what are some other laws that we got to be familiar with? So Poiseuille's law states that flow equals to a change in pressure over resistance, okay? And while we won't talk about Poiseuille's law in this video, it's still important to know it. And the relationships here are going to be that pressure is directly proportional to flow and that resistance is inversely proportional to flow, okay? Meaning that if I increase my resistance, flow goes down, okay? And it's a very simple concept to grasp. So for example, let's say that this part of the bronchioles or bronchus or trachea is blocked, okay? Is air going to be able to flow easily into this? No, right? So my resistance is high because of this blockage and my flow is down, okay? Easy. And pressure and flow are very directly proportional, and you'll see this later on when we talk about it. If I increase the pressure in a system, the flow is going to go up as well. It's almost directly proportional and linear depending on where we're talking about. For example, in the circulatory system, there are some exceptions. Now, before I get to these guys, I want to talk very quickly about what determines pressure. So pressure obviously is determined by volume. And we actually mentioned that right here with Boyle's law, right? The lower the volume, the higher the pressure. The higher the volume, the lower the pressure. Cool. It's also derived from temperature. So temperature can definitely determine pressure. So I'm not going to talk too much about pressure as regards to temperature because it's a giant wormhole to go down and you can easily do a whole nother video on it. But generally, for example, if it is cold outside, the lung has to work a little bit harder, meaning create a bigger pressure gradient to bring in that air, generally speaking. But I'm not going to cover it too much. Anyways, when it comes to the final thing that determines pressure, that is the number of molecules. Number of molecules, okay? So obviously, and again, generally speaking, the number of molecules plays a role here. So if you have a high number of molecules, right, high number, that means you got a high pressure. If you got a low number, you got a lower pressure, okay? And again, if any of you have taken chemistry, you might relate this to the ideal gas law with this formula, okay? But we're not covering that today. Okay, so let's get back to these two pressures here. The transpulmonary pressure, sometimes also called the recoil pressure. And then finally, there's another one that's called the transwall and the thoracic pressure, or the transthoracic pressure. Okay, I'm going to leave these blank for now until next slide when we start talking about different gradients, okay? But first things first, what do I mean when I say a pressure gradient? Guys, this is so key to understand. You can think of a pressure gradient as this kind of like little step. Boom, 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 boom. Things that are usually in a high area are concentrated in a high area, okay? They don't like to be there. They want to move down their gradient into somewhere that is low concentration, okay? For example, if we have a high amount of oxygen in the atmosphere, okay, and we have a low amount of oxygen in the lung, okay, where does the air want to go? It wants to go from the atmosphere into the lung, okay? Very basic example, but that's just for you guys to understand, okay? Things like to always move from high to low, okay? That's just how it is. That's the pressure gradient, okay? We're taking our steps down. All right, that's very important to understand. Now, last thing is in regards to the anatomy of the lung is going to be, what is the most basic functional unit of the lung, okay? So you know that it's, keeping a branching and all of that. That's great. But then where does all of that leave eventually? Where does that leave? Well, it leads us to these little sacs of air. these little sacs of air are actually called alveolar sacs, okay? And for the purposes of this video, gas exchange or respiration, okay, occurs at the level of the alveolar sacs or alveoli, okay? If you're curious, it can occur somewhere a little bit above that at the respiratory zone, but for the purposes of this video, it can occur at the alveolar sacs, okay? We'll keep it that way. All right. Now, you know the lung, it doesn't just breathe in and breathe out on its own, right? That's not what's actually happening. What's happening is the muscles around the thoracic cavity and the rib cage pull on the rib cage to create pressure gradients, thus making the lung inflate and deflate, okay? And we'll look at that in detail. But what are some of those muscles? So the muscles of inspiration are going to include things like the sternocleidomastoid, okay? And you know, the muscles I've included here, they might not be direct insertion and origins, but this is just for you to get an idea of where their whereabouts is approximately, okay? So, for example, the sternocleidomastoid would definitely be around here. The next muscles is the scalenes, okay? We have other ones, like the external intercostals. People get very confused often by this one because they think that because external intercostal has an E in it, it has to be for expiration. I like to think of it as the opposite. Because it has an E in it, and you think it should be expiration, it's actually for inspiration, okay? So you can think of it as IE if you want, okay? Inspiration, external intercostals. This one would be the exact opposite, and we'll see that later. So that's that. The other muscle that's around here, okay, is going to be called the parasternal intercostals. Intercostals. Okay? Awesome. And then finally, the main muscle of inspiration is going to be this dome-shaped muscle. We've already named it before, but it's called the diaphragm. The diaphragm, big muscle when it comes to inspiration, okay? In fact, 75% of the enlargement of the thoracic cavity during just quiet breathing, quiet respiration, is due to the contraction and flattening of the diaphragm, okay? So 75% is just due to the diaphragm, all right? Another fact is that the diaphragm's activity during normal, regular, quiet breathing represents about 1% of total body VO2. Total body VO2. If you guys don't know what VO2 is, VO2 stands for the volume of oxygen uptake, okay? Volume of oxygen uptake. And the activity of the diaphragm represents 1% of that, of your total body oxygen uptake. That's pretty big if you think about it, okay? All right. What about the muscles of expiration? Okay, I gotta point out something key here. So let's change the color. And this is the big note here, is that muscles of expiration are not used during quiet, normal breathing. Now, I've used the term quiet breathing pretty commonly now. What do I mean by it? Well, the fancy name for it is called eupnea, okay? Eupnea, normal, regular, quiet breathing. And it's about 12 to 20 breaths per minute. Obviously, this can differ a bit, but this is a range, so 12 to 20 breaths per minute. And the important thing to realize here is that during eupnea, or regular, normal, quiet breathing, there are no expiratory muscles involved, okay? There are no expiratory muscles used. It is only the lung's elastic recoil. Elastic recoil. Okay, that's important. That's very important. Okay, now let's talk about the muscles of expiration. In fact, the muscles of expiration are the ones that you use, for example, during exercise or accelerated breathing. You know another name we call that? We call that hyperpnea. That's accelerated breathing, okay? Anyways, Those muscles are going to involve the internal intercostals. So the internal intercostals, okay? Now, with this one, again, it has an I in it, so you would be tempted to think that it's for inspiration, but really it's the exact opposite. It's for expiration. So again, same as that external intercostal. All right, next we have this muscle here, the external oblique. External oblique. And basically all of the abdominal muscles. So for example, the rectus abdominis, and then we also have the internal oblique. Okay. Okay. Now, the last one being the transversus abdominis. Okay, the transversus abdominis. Basically all of these muscles. So what are all of these muscles doing and how are they doing it? Okay. I'm going to give you a rundown of it. The inspiratory muscles, their aim is to increase the volume in the thoracic cavity. And actually, we abbreviate it as increase the thoracic cavity volume. And in doing so, following Boyle's law, they're going to decrease the thoracic cavity pressure. You can think of this pressure as the pressure that's inside of the alveoli. The pressure that's inside of the alveoli, okay? Awesome. So the inspiratory muscles are going to aim to increase the thoracic cavity volume, and they're going to decrease the thoracic cavity pressure because of that Boyle's law. Expiratory muscles, their aim is to do the exact opposite. They're going to try and decrease the thoracic cavity volume and increase the thoracic cavity pressure. So why are they doing this? So the goal with inspiration is to bring air into the lung, right? Now, I'm going to tell you this right now. Regularly, the atmospheric pressure is around 0 centimeters of water, okay? Centimeters of water is just a unit of measurement, okay? So like liters, okay? Or milliliters, something like that, okay? You can also write it as 760 millimeters of mercury. Now, at rest, usually inside of the lung, the pressure in the alveoli is 0 centimeters of water. So tell me something, if the pressure is 0 outside and 0 inside, is there going to be any air movement? Well, if you said no, good job. There is no air movement because there's no pressure gradient. But what do I have to do in order to move air in during inspiration? I'll tell you what, I got to increase the volume in the thoracic cavity, which will decrease the pressure. Why would I want to decrease the pressure, guys? If I decrease the pressure, let's say to -1 centimeters of water, which one's higher now? 0 or -1? 0 is higher. 0 is higher. So what is that going to do? Air is going to move from an area of high to an area of low, okay? That's what's going to happen. That's the exact goal of inspiration. They're going to try and create a negative pressure to move air in. And it's the exact opposite with expiration. For example, with expiration, again, the atmosphere pressure is the same. It's 0 centimeters of water, okay? But now I want to move air out. So what do? I have to create a positive pressure. Let's say +1 centimeters. And that's going to push air from a high location to a low location, okay? That is why we're doing this. That's why we're doing this, okay? All right. Now, with all of that known, let's go ahead and talk about respiratory mechanics and how we're breathing, okay? We're going to take snapshots of the lung at rest during the onset of inspiration and the end of inspiration, and then at the onset of expiration. And if you're wondering, hey, why is there no end of expiration? Is because this situation at rest can also be thought of as the end of expiration. End of expiration, transitioning to rest, okay? So you can think of it as that. Okay, let's get started. So there's a couple of abbreviations that I'm going to introduce here, and that's because respiratory physiologists love their abbreviations, okay? So first things first, the pressure in the atmosphere. is going to be depicted as big P for pressure, and then ATM for atmosphere, which in the last slide I told you is about 0 centimeters of water or 760 millimeters of mercury, okay? Now, I have it all written down. Well, actually, not yet, but we're going to write it down here. So let's write it down here. At rest, 0 centimeters of water and 760 millimeters of mercury. Awesome. Cool. What else? Also at rest, we have a pressure inside of the lung, but more specifically inside of the alveoli. Remember alveoli? I said the alveolar sac? That there's a pressure there, okay? And at rest, that's also 0 centimeters of water, or again, you can write it as 760 millimeters of mercury. Now, a quick note about the atmospheric pressure. Another name for it is actually called the barometric pressure. And this guy genuinely will remain constant. Okay, so this is the pressure at sea level. So about where you're sitting right now, unless you're watching this at Mount Everest. So it's about this. And usually at sea level, it's 760. But as soon as I start going up to altitudes, okay, greater than approximately 1,000 meters, okay, and this can change, okay, this pressure starts to drop, okay. So for example, at the top of Mount Everest, the barometric or the atmospheric pressure is about 440 millimeters of mercury, okay? So that's going to affect the way you breathe. Okay. Now, remember that I told you at the start that there is a potential space in this cavity, okay? And that's primarily due to the fact that the lungs are pulling the visceral pleura inwards and the chest wall is pulling the parietal pleura outwards. And that's creating a space here which, because the volume in that area is increasing, the pressure in there is decreasing. It literally is a negative space. It's literally a negative space. And what is the value? Okay, what is the value of the pressure there? It's about -5 centimeters of water. Okay, and you can also write this as 755. Okay, so -5 centimeters of water, or 755 millimeters of mercury. Okay, millimeters of mercury. The alveolar pressure we said was about 0 centimeters of water and 760 millimeters of mercury. Okay, cool. Now, with this said, I gotta introduce you to another concept as well, with the transpulmonary and the transthoracic or the transwall pressure. Okay, we've already talked about these before, so we've already briefly mentioned them here, and now I'm going to give you the formulas for them. Okay, so the transpulmonary or the recoil pressure, the formula for it goes something like this. Okay, it is, and you can write it down like this. You can write down P transpulmonary, and it'll go like this: the pressure in the alveoli subtracted by the pressure of the intrapleural space. Okay, or the pleural cavity. Okay, that's going to be the transpulmonary pressure. The transwall or the transthoracic pressure can be written like this. So transwall equals to the difference between the intrapleural pressure and the atmospheric pressure. Okay, and you'll come to find that if you have no pathologies, it should just be the same as the intrapleural pressure. Okay. All right. Now, another thing I have to mention is that both the transpulmonary and the transwall pressure, they both fall under a category called the transmural pressure. Okay, so they're both transmural pressures, but there's just different types. Okay, so there's two types, and there's the transpulmonary and there's the transwall. Transmural. Boom. Okay, now that we know this, let's take a look at it visually. Okay, so here's the pressure in the alveoli, and here's the pressure in the intrapleural space, and you can see it's the pressure against that wall. Okay, it's the pressure all throughout that wall, and same here. Okay, it's the pressure between the intrapleural space and the atmosphere is right here. across that wall, okay? Now, this pressure is the most important one here, okay? This is the pressure that, technically, you can say it like this. This is the pressure that actually stretches the lung. Remember I said the lung, it's very lazy, okay? It doesn't want to be stretched. It wants to recoil to the smallest size possible. But this guy here, okay, this transpulmonary pressure, it keeps the lung in a stretched out position, okay? Keeps the lung in a stretched out position, all right? And it basically counteracts the lung's intrinsic elastic recoil, okay? You want this pressure to be positive. If this number, this pressure of this number ever becomes negative, that means the lung is collapsed, okay? So you want this to be positive. And obviously it can go up a bit positive, but it can go down a bit positive as well. And we'll see that, okay? All right. But as long as this pressure is positive, it means that it's inflated. It means that it's inflated. A little more on the muscles of inspiration and expiration. So the muscles of inspiration, like I said, their goal is to increase the space in the cavity of the thoracic cavity, right? And how are they going to do that? Well, the scalenes, let's increase the size of this, actually. So, for example, the scalenes and the sternocleidomastoid, they're going to pull on the bones and elevate both the clavicle, the ribs, and the sternum. Okay, this is the sternum. The external intercostals are going to pull this way, okay? And they're going to actually open up the ribs like a kind of a handle movement, okay? You can imagine it's happening on both sides, okay? All of this is happening on both sides. And they're going to kind of open up the rib cage, okay? The parasternal intercostal will also pull the rib up and out, okay? So far, we've pulled the sternum up and out. We've pulled the clavicle up, and we've also pulled the rib cage up and out, okay? The diaphragm, being the main inspiratory muscle, when it contracts, instead of being in this dome shape, it's actually going to look something like this. And if it plops down, which you can see right here, so instead of being dome shape, it actually plops down and increases space vertically for the lungs to expand into, okay? That's very important. That's very important. What about the expiratory muscles? What are they doing? Where they're going to act the exact opposite. So the internal intercostals, instead of pulling up, they're going to pull down, okay? They're going to make the ribs or the rib cage even tighter, okay? Even tighter, pressing on the lungs, decreasing the space and increasing the pressure. What about all of the muscles here, okay? Well, the external intercostals, they're going to kind of pull down on the ribs. Again, same thing. Not intercostal, the external oblique. They're going to pull down on the ribs. The rectus abdominis and the transverse abdominis and all these other guys, they're going to exert a pressure like this, okay? And what I mean like this, they're going to push inwards when they contract, and they're going to create a pressure inside of this abdominal cavity, okay? So abdominal cavity. And once that pressure in the abdominal cavity goes up, it is going to push on the diaphragm, okay? And once it pushes on the diaphragm, it changes its normal like dome shape into something like this, okay? Which again pushes on the lungs that are in here, decreasing the space, increasing the pressure even more, okay? Nice. All right, now let's go ahead and start talking about the changes that occur with inspiration and expiration. This shouldn't take very long now that we know all these concepts. So, let's go ahead and take a look here at how we calculate this number, okay? So let's bring this back down a bit to 4. The pressure in the alveoli at rest is 0. The pressure in the intrapleural space is -5. So if I do 0 minus -5, that gives me +5, okay? So that means that my transpulmonary pressure at rest is +5 centimeters of water, okay? Or you can say 765 millimeters of mercury, okay? So that's that. But the centimeters of water, I find it easier to use. Now let's calculate the transwall pressure. The transwall pressure, guys, is the difference between the intrapleural space and the atmospheric pressure. So if we have -5 minus 0, which is the atmospheric pressure, what is that going to give us? That's going to give us -5 centimeters of water. -5 centimeters of water, or 755 millimeters of mercury. Okay. Now I'm going to leave this chart here. You guys can, screenshot it and fill it out on yourself if you want. But I'm going to fill this out from now on, okay? All right. Just want to show you guys how to calculate it. I don't want this video to be too long. Now, during inspiration, what did I say our aim is to do? During inspiration, our goal is to make the thoracic cavity volume bigger, thus decreasing the thoracic cavity pressure to suck air in. Okay, cool. So the atmospheric pressure always is the same unless you're in altitude. It's 0 centimeters of water. I'm not going to write the units. And the alveolar pressure, you know what's going to happen actually? The diaphragm is going to contract. How? You guys know that, your brain, okay? Actually, you know what? I'll do it like this. The nerve that actually innervates the diaphragm is the phrenic nerve. Okay, the phrenic nerve, and it gets its roots from C3, C4, C5, okay? And the phrenic nerve causes this diaphragm to contract. Once it contracts, it's going to dome downward, increasing the space for the lungs to expand into. When it does that, that's going to create a pressure, okay? That's going to create a pressure. And how does it create that pressure? It creates that pressure by increasing the volume. Because it increased the volume, it's going to lower the pressure. With that said, the pressure in the alveoli will now become -1. Okay? And you might be thinking, well, hey, how is this happening? How are the lungs expanding? Well, you got to remember that the visceral pleura and the parietal pleura are very closely touching. They're almost actually attached to one another, almost. And the parietal pleura is not only attached to the chest wall, but it's also attached to the diaphragm. So when the diaphragm contracts, it's going to pull the parietal pleura, which will then pull the visceral pleura, which will then increase the lung, okay? It'll expand the lung, okay? All right, great. That's that. Now, the pressure inside the alveoli is going to be -1, okay? Which means what? 0 to -1, okay? From high to low, things will start flowing down. Now, as this is happening, the lungs are expanding more and more and more into that pleural cavity, okay, that pleural space. So you had rest, it was pretty big, but now it's pretty small. So what is the number going to be in there if I am lowering the volume inside of the pleural space? Well, you would expect the pressure to go up. And you were right. It goes to about -6, okay? Goes to about -6. All right. Now, when I say it goes up, it's going up in the opposite direction, right? So we have 0 here. We got 1, 2, and then we got -1, -2, okay? This pressure is going up, but in the negative direction, all right? Awesome. Now, what about at the end of inspiration? Well, at the end of inspiration, you have breathed in so much that your lungs are almost at the top of your breath. You cannot bring more air in. Your lungs are completely expanded, and they are almost decreasing the space here completely in this parietal space, okay? So what's going to be this the pressure in the intrapleural space? It's going to be -8, okay? The volume in this space has decreased so much that the pressure has increased so much in the negative direction, okay? All right. And you guys can obviously do the math on that and calculate the transpulmonary pressure, which actually at the onset of inspiration is going to be about +5. So it's about +5. And at the end of inspiration, it's going to be about +8, okay? So the more positive this guy gets, this transpulmonary pressure, the more inflated the lung is. The less positive it gets, the less inflated the lung is, okay? So at the onset of inspiration, the transpulmonary pressure was the same as rest. But then at the end of inspiration, it became more positive, meaning that the lung is becoming more inflated. Okay, keep that in mind. Now, the alveolar pressure, what is it going to be? If you said that the alveolar pressure is actually going to be even more negative, you're wrong. It's going to actually be zero. Why would it be zero? Remember, guys, things like to move from a pressure of high to low, but they do that until they equilibrate. Okay, they equilibrate, they reach equilibrium. So we're going to keep breathing in this 760, all right, when this is 759, and this air is going to keep coming in until it makes the inside of the alveoli 760 or zero. Okay? Awesome. So that's how inspiration works. Now, passive expiration, meaning I'm not using any expiratory muscles, is going to look something like this, where the diaphragm, after it's no longer being innervated by the phrenic nerve, will just go back and relax. And as it's relaxing, it's going to dome up again. It's going to turn into that dome shape. And that's going to actually pull, actually push on the lungs to, recoil to the small size possible. And again, the lungs, very much happy to oblige, they will recoil. Okay? Now, they won't recoil to the point of collapsing because you always have to have some sort of residual volume inside of the lungs to keep them inflated. Because if they collapse completely, it is damn near impossible to reinflate them, and you have to surgically go in and inflate them. Okay, you got to run a tube there, and it's just not comfortable. So, what does the pressure changes look like during expiration, specifically the onset? And it's going to be something like this. Okay, the atmospheric pressure, again, always zero. But now the goal here is to create a high pressure here to move air out. Okay, move air out because I'm done. Now, what is that? How do you create that high pressure? Again, the diaphragm domes back up, lowering the space that it initially created here. Okay, forcing the lungs to actually move back and recoil. Okay, recoil that way. And the pressure inside of the alveoli will rise to about +1, which means now air will go out, okay? Out until it reaches equilibrium again. And the alveolar pressure at the end of expiration, which we said could be viewed as this rest scenario, would be zero again, okay? Awesome. Now, what do you notice about the intrapleural space? Because the lung recoiled, okay? And again, this is greatly exaggerated, but because the lung recoiled, it increased the volume inside of this space ever so slightly, okay? Ever so slightly, meaning that it actually made the pressure here decrease to -7, okay? -7. Before it was -8, and now it's -7, okay? And as the lung continues to reach equilibrium and relax back to its normal size, what's going to happen? This intrapleural pressure will go back to being -5. Alveolar pressure will be zero again, okay? Everything will go back to being normal. Now, if you calculate the transpulmonary pressure again, this pressure right here, you would notice that you have a +1 and you got a -7, and that's going to be +8. Now, you might be thinking, hey, why is the transpulmonary pressure the same at the onset of expiration as it was at the end of inspiration? Because it's at the onset. We just started. Okay, but if you look at the end of expiration, which we said was this rest scenario, it went back to being +5. Okay, it went back to being +5. So again, the less positive that transpulmonary pressure is, you can think of it as deflating the lung, but the more positive it is, you can think of it as inflating the lung. However, the correct way to understand this is that as long as this number is positive, the lung is inflated. Whether it's a little bit more or a little bit less, doesn't really matter. It's inflated. If the number becomes negative, like it literally becomes negative, that means the lungs are completely collapsed. Okay? And that can actually happen in traumatic scenarios, for example, in pneumothorax. Okay? Pneumothorax, you can actually puncture a hole inside of this pleural cavity, okay, which basically means that I literally do this. Watch. I create a hole for air to come in from that chest wall into the pleural space. And that air is going to keep going in and out, in and out, in and out until it makes the pressure in the intrapleural space, instead of it being negative, it'll make it zero. If this pressure is zero and the pressure in the alveoli is zero, and I subtract this by this, the transpulmonary pressure becomes zero. What does that mean? That means the lungs fully collapsed. Okay? So that's pneumothorax right there. And this would classify as traumatic pneumothorax. There is another one, like spontaneous pneumothorax, which means that the lung tissue itself will actually burst and create an opening. Okay, so meaning that this is intact, but the lung tissue will burst and create an opening to this intrapleural cavity. Okay, so you always want the intrapleural cavity to be negative. Okay, if it's not, you're not breathing. All right. Okay. That's going to be it for respiratory mechanics, everybody. Again, I'm going to leave this here for you guys to fill. Okay. If you enjoy the video, please like, subscribe, and if you have any questions, comment. This will be an ongoing playlist in the human physiology playlist. Okay. Thank you for watching.